NYU. So I'll show you his cytology, histology, normal histology. Normal liver.
I think you might want to press mute on your stuff.
Normal liver has the central vein and portal triad. Portal triad has arterial, bile, ductal, and vein. And then they're very organized going to central vein. And that's what we learn in histology. It's very important to understand the normal liver. And all the hepatocytes, they're very organized. Everything's organized. This is tricone stain to show the central vein and the portal triad with 3 vessels, and you have rows of hepatocytes leading to the central vein. And this is just normal histology. Cytology. The normal hepatocytes look like kitchen tiles. It's polygonal, very straight edges. You see, because it has a abundant cytoplasm and canaliculi forming straight borders. And this is bile plaque. So everything's down from normal. And this is a cover cell. And those ductules are bile ductules. So mass lesion is not tumor. There's a case, old case, 34-year-old woman from Bosnia. She is healthy but has elevated liver function test. And then CT shows a nodule. Aspiration shows very dirty background and then some thick refractile substance. And then some epithelium and very thick wall, and high power shows echinococcus in here. So it's a hydatid cyst, echinococcus granulosus. Of course, this case, I wasn't that brilliant. I just say benign liver cyst. And then the clinician was so brilliant. He called me up, said he suspects patient has the hydatid cyst because she's from Bosnia. And then he asked me to review the slides. And now I know what to look for. And so this is the case. And then benign mesenchymal tumors in the liver. The old case, 60-year-old man, incidental finding of a liver mass. Here's the CT-guided FNA, here's the liver mass. Everything's normal. And the aspirate was very, very bloody, blood everywhere. And then you have those spindle cells. This is a clue for cavernous hemangioma. And this is ultrafast pap stain of a piece, lyse blood to show the arrangement. You see, have endothelial lining and fibroblasts. And so when you have cavernous hemangioma, it's very important to request the radiologist to do a core biopsy, because nothing will happen, and it will be diagnostic. Here it is. Because very few people could concur with cytologic diagnosis of cavernous hemangioma, but everyone could recognize histology. The NYU case, 48-year-old woman with 10 centimeter liver mass. And then have some really weird cells. There's a lipid droplet in the background. Look like outside. It's really strange. And then this ultrafast PET shows some fat droplets, and then the tumor cells look like prominent nucleoli. Really strange. So what could this be? The cell block shows you could do, even though you have thick wall blood vessels, that's angio. And then the tumor cells are actin positive, HMB45 positive. So mild melanocytic tumor cells. So it's mild. And then you have mature adipose tissue, so angiomyolipoma. Because the radiologists don't usually think of liver hepatic angiomyolipoma. That's why they do the finding aspiration. If it's in kidney, they would just call it, so you never get to aspirate. So mean age 50 years, mostly women, may have concurrent renal angiomyolipoma. 10% have tuberous sclerosis. And this is an example of PEComa. Hepatic angiomyolipoma. PEComa is perivascular epithelial cell, PEC, tumors. So over. So the family of PEComa include, in addition to angiomyolipoma, also have clear cell sugar tumor of the lung, lymphangiomyomatosis of bronchial, abdominal pelvic sarcoma, clear cell myelocytic tumor of falciform ligament. And so that's the example. And one thing is, when you're doing on-site assessment, how do you separate benign liver aspirate from adequate liver FNA immediately during assessment? Because if the liver nodule is small, they may not target the right spot. And because I did a lot on-site at NYU, so I noticed one thing, the physical feature of liver aspirate. Me and the colleague published a paper in Modern Pathology 2004 to show the histology basis of our finding. You see, benign liver lesions, they're very organized. They have layers of reticular fiber. So when I try to make a good smear, I just couldn't break it. If you use very hard, try to break it, they're very rigid because they have a layer of reticular fiber to prevent it to make nice smear. But in hepatocellular carcinoma, the reticulum fiber is markedly reduced. So it doesn't have the structure. When you make a smear, you could make a beautiful smear. They're all granular. And that, why the liver aspirate is granular, because the reticulum fiber is gone. So that's cool, because liver pathologists use reticulum stain for difficult liver core biopsy. It's very important, the presence of the reticulum fiber. So here I'm going to show you benign liver lesions. Here's a lot of cells, kind of some big cells, some small cells, but they're very cohesive. And some binuclear cells. In the cell block, the reticulum fiber is intact. So it's cirrhosis, macro-regenerative nodule. A case had a young man, he's fine except increased liver function test. CT shows a big liver mass, but he looks fine, just elevated liver function test. This liver nodule on CT is circumscribed, heterogeneous. And in arterial phase enhancement, venous phase rapid washout with the enhancement of central scar. Those are the radiology proof for this lesion. And aspiration shows very cohesive, some fibrous tissue and some liver cells. You see, the liver, the hepatocyte still is like kitchen tiles. This is an example of focal nodular hyperplasia. It's hyperplastic response to arterial malformation. Fibrous septa radiating from a central cellulate scar containing vascular structure. That woman with a big mass shows this is a liver abscess, very cohesive. And kitchen tiles. Intact reticulum fiber. The histology follow-up is liver cell adenoma. The histology is liver parenchyma, but without triads or bile duct. It's just pure hepatocyte. Sometimes associated with oral contraceptive use. Mostly solitary, 10% multiple. And when it gets to be too big, it may rupture, leading to hemorrhage. And now, hepatocellular carcinoma associated with hepatitis virus B from placenta from mother to baby, hepatitis C from blood transfusion, and usually have cirrhotic liver. Here's a diagram. Benign hepatocyte, malignant hepatocyte. Benign hepatocyte look like kitchen tiles because you have canaliculi. a malignant hepatocyte. A reticulum fiber reduced, cytoplasm reduced. Nuclear size is constant, but cytoplasm reduced. Because cytoplasm reduced, so you have increased nuclear density. See, once it becomes malignant, become like this. Occasionally you have small malignant hepatocyte with kitchen tiles, but it's rare. Most of them are round up. You see high NC ratio, same size nucleus, nucleoli, but cytoplasm reduced. Here's a teaching case I had at NYU. Same FNA smear of a very small liver lesion. Abundant cytoplasm reticulum. Is it rounded and increased NC ratio? And because that target's only 2 cm, and so the sample contains some benign liver and malignant liver hepatocyte. And I use this case for teaching because everything is the same smear, but they just at the very helpful in learning the cytology. See, the reticulum fiber will be intact. Here will be reduced. You see, that case is the same cell block. This is benign, this is malignant. You see, increased new. And reticulum fiber. See, intact, reduced. It's really very helpful. Same case. So here's a typical Chinese man with liver mass. Just for why do I classify this as for recognition? Well differentiated, moderate differentiated, poorly differentiated hepatocellular carcinoma. And also pleomorphic giant cell type. This is a classic trabecular pattern. You recognize it, low power. Trabecular pattern, low power crew. And you have this endothelial lining. The classic textbook. And you see the high power, look at this. You see high NC ratio, no kitchen tiles, clone look like each other, one another. It's classic, everybody recognizes this. And when I was in NYU, I had cases like this. It was granular smear, have trabecular, but there's no endothelial lining. You have reduced cytoplasm, but no endothelial, and the lesion was previously called reactive liver, and then it shows up in bone metastasis. So I went back to the original case. I recognized this was not described in cytology literature. And another pattern is the liver aspirates granular, but look like follicles, really strange. Almost like a thyroid. It's really strange. And there's no endothelial lining, and this cell block reduced reticulum, and it's bicosanoid type. Because I collected a series of this type, so I contacted Dr. Leochita. He described the classic type. I said, how come in your textbook you didn't describe this? He said, actually, I saw before my retirement. I said, if you truly believe, would you be the co-author? And he agreed. That's why we publish it in Cancer Cytohistology. And another type is have a lot of fat droplets. Actually, it's not fat, it's glycogen. So it's hepatocellular carcinoma, stereotactics, clear cell. It's very rare, only have one case found on OIU. And moderate differential CC is the easiest to diagnose. If you know this through, you don't need anything. Because this type, they're very fragile. Cytoplasm are very fragile. When I smear, it bursted and release thousands of naked nuclei into the smear. And then the nuclear feature of naked nuclei identical to nuclear intact cells. Here's a typical border differential. You see, thousands of naked nuclei is some intact. And the nuclei are typical for hepatocyte. The intact cells, they're identical. It's just abnormally fragile. And here's the cell block. And with this is a classic for rather differentiated hepatocellular carcinoma. And sometimes HCC have malignant hepatocyte with abundant cytoplasm like this. Macronucleoli. And here's you see, macronucleoli, fully differentiated hepatocellular carcinoma. To familiar with different phases of HCC. And the purpose of classification is so your mind's eye is programmed to this. So if you have an aspirin look exactly like this, you will recognize it. And I have an AIDS patient with, it doesn't fit with any of this pattern, but very high alpha fetoprotein level. See, look, fully differentiated. It's positive for alpha fetoprotein. This is another presentation. And another is pleomorphic giant cell type. And now fibrolamellar carcinoma of liver has nothing to do with hepatitis. Used to be a histology, now it's separate. It's not hepatocellular carcinoma anymore. Young patient, equal gender presentation, no association with hepatitis, and no cirrhosis. Prognosis is a little bit better. When you case young man with, he had already had the history of resection of 10 centimeter liver tumor, which is fibrolamellar carcinoma. now they want to rule out metastasis in the lymph node. So this is dipquick. You have fibrous tissue, and you have the giant cell. Look like outside, very distinct cytoplasm cytology feature. It's cell block, fibrolamellar carcinoma liver. All this is morphology. And CT scan show liver with central scar. Histology shows thin columns, large nodules or tumor, separated by fibrolamellar, composed of many thin hyalinized bands of layers. Granular smear. Giant tumors are like eyeball-like nucleus. Another is hepatoblastoma in pediatric or young adult. Most common, I also have several cases from NYU. It mimic developing embryonal and fetal liver, including extramedullary hematopoiesis. Very high level of alpha-fetoprotein. And while I was at Cornell, at that time, cytology was in Stat 10 next to surgical pathology. So I did a lot of bench smear because you always know the recut, the tissue follow. So while the bench smear I did, it's hepatoblastoma. See, here you have megakaryocyte. This is phenotype. And then I have other types. This is embryonal type and phenotype. In that particular case, it's combined embryonal and fetal type. A boy with large liver mass, elevated alpha-fetoprotein. Tumor cell, primitive hepatocyte, and then some mesenchymal tissue. So it's an example of mixed epithelial mesenchymal type of hepatocellular carcinoma. And intrahepatic bile duct tumor, benign small firm nodule, usually beneath Gleason's capsule, usually solitary, but sometimes multiple could mimic metastatic carcinoma, composed of small, well-formed bile duct embedded in mature some. Here's FNA of bile duct adenoma, the cytology. A cholangiocarcinoma, first we reviewed the bile duct all the way to pancreatic duct, the same kind of ductal epithelium. And cholangiocarcinoma is from this anatomic side. Much less common than HCC, associated with coronal infestation, hemochromatosis, and thorax. Long-standing ulcerative colitis. Histology is ductal type adenocarcinoma of the cuboidal or columnar cell type. more fibroblastoma. Here's a case. The core biopsy of the same case. And another cholangiocarcinoma, they have some secretion. Not a lot, but it's just different phases of the tumor. And here's a primary sarcoma, angiosarcoma. Most common primary sarcoma of the adult liver. 10 to 20 cases per year in the US associated with all this toxin. Usually it's elderly disease, abdominal pain, multiple, less often solitary hemorrhagic masses, thrombosis, infarctions are common. Both open. You see, in this case, large core needle core biopsy are associated with intra-abdominal bleeding, so core biopsy is contraindicated if you suspect angiosarcoma. FNA using 25 gauge needle reduce this hazard greatly. Here's a case I signed out. Diffuse infiltrated lesion involving left lobe with satellite nodule at the right lobe. FNA is direct transabdominal FNA of liver. See, it was very bloody and there's some weird stuff. And then our ultrafast biopsy lines the blood, you realize it's the stuff is capillary, a network of blood vessel. But the blood vessel is malignant. Endothelial cells are very big. Here's the core biopsy, concurrent core biopsy. So this is a nice example of angiosarcoma of cavernous type. And there's another type, this 46-year-old man, history of hairy cell leukemia, abdominal pain. CT scan shows heterogeneous liver with multiple areas of low attenuation. This is difficult of like mesenchymal tissue. It's very difficult to recognize. You need cell block. Here's the cell block. So cell block shows the angiosarcoma. It's elevated the liver. Oh, I remember this case. This 50-year-old African-American man, he looked healthy. Actually, he looked younger than his age, looked like 38. Elevated liver function test. There are multiple liver masses. The thing is, he looked like has metastatic disease, yet he looked healthy. What's going on? And the FNA shows this after our ultrafast biopsy have this weird cell. Very strange. Very interesting. And then the composite of the tumor cells shows intracytoplasmic lumina. Very beautiful cells. And this case is really difficult to diagnose by cytology. You need a cell block or core biopsy. It's epithelial hemangioendothelioma, trichomsy, to show the tumor cells in fibrous matrix. Here's what I just show you, single this birth cells, occasional police. Then cytoplasm with well-defined border, cytoplasmic lumina. Sometimes you have the red blood cells in it. Then stroma. It's epithelial hemangioendothelioma. It's vascular tuber intermediate aggressiveness, asymptomatic man with liver function test. Multiple liver mass with non-primary. It's a very important diagnosis because if you could diagnose it, the patient would be eligible with a liver transplant and he'll be cured. And when you suspect this, you have to need cell block or core biopsy to make the diagnosis. Clinically, it's a healthy-looking man, mostly men, with multiple liver nodules, yet he doesn't look that sick. So this is a vivo. That's what I just showed you. And here's a summary of my NYU experience, and with Dr. Liao Chitao. That's a hepatocellular carcinoma, classic type, with endothelial lining with retraction. Okay, that's it.
Thank you.
Yeah.
Thank you very much. That was terrific.
Well,
I don't see any questions.
Okay. Any questions?
I don't see any.
Okay.
Thank you so much. We really appreciate all your lectures you've given us all over the years.
Well, it's a pleasure.